All right. Good morning or afternoon or night, wherever you're watching this. My name's Richard,
And I'm Kelly.
and we're presenting for our group project CTA head and neck, specifically for stroke. So we first wanted to go through and kind of just give everyone an explanation of what they do for the CTA head and neck stroke. So this exam is normally ordered when there's currently a stroke suspected happening with the patient. They're presenting symptoms of a stroke, or a physician is concerned that a stroke has occurred recently. The first part of the exam normally done is a CT head without contrast, and then the neurologist or radiologist will make decisions based on that first scan about what they want to do, and then normally an MR follows thereafter. This exam is normally done looking for stenoses or blockage, hemorrhage, or filling defects within the arterial system of the head and neck. And it is also used as a tool for differentiation between ischemic or hemorrhagic strokes, just to give the neurologist an idea of which path they need to go down for procedure and treatment of the patient's condition.
All right, just to reiterate what Richard was saying, the exam is usually ordered before the stroke happens, but we decided to follow a case that was a little bit out of the norm, and you'll see why in a moment here. So this patient showed up in the ER with symptoms of right-sided facial drooping and severe aphasia. He was nonverbal except saying 1, 2, 1, 2, and also just very simple yeses and nos, maybe just with the nod of his head. And the reason why this case was kind of special is because he already has a history of recurrent strokes. So before that, he has hypertension, diabetes mellitus, obstructive sleep apnea, chronic pain, and chronic kidney disease. But although he has this disease, it said his baseline creatinine was 1.4, and he showed up in the ER with a level of 1.24, which is still considered to be normal. So that's why it was okay for them to continue with the CT exam. This patient also had a known left MCA stenosis, which is the middle cerebral artery. It's the largest cerebral artery, and it's the most common site for a stroke. He also has recurrent strokes in the left MCA, once in June of last year and December, and he has encephalomalacia involving the left temporal, parietal, and occipital lobes, which is just the softening or loss of brain tissue after a cerebral infarction. And the day before the CT exam, he had a new left parietal stroke that was confirmed with MR. So they decided to order the CT exam to just rule out a new thrombus in that middle cerebral artery.
Okay, so the reason why they ordered this exam, the reason why they normally choose CT as their modality in a stroke code situation is, like many of you have already heard, time lost is brain lost. So efficiency of visualizing all of the arteries and visualizing the brain is of utmost importance. So CT is the fastest modality for doing that.
Yeah, so in the specific case of this patient, like I said, he already has a history of stroke, and he had prior CT and MR exams. And again, they just wanted to rule out a new thrombus.
right, so for this exam, IV contrast is used. In my clinical site, they use Omnipig 350. And it is a multi-phase, so they'll first do a scan without contrast, a non-contrast scan of the head, and then they'll do in our arterial phase, otherwise known as the bolus phase, which is just usually scanned about 10 to 20 seconds following injection of contrast from the aortic arch to the vertex of the skull. And then they'll also do a venous phase, or what is also called the non-equilibrium phase, which is scan like a minute and a half to 2 minutes prior to the injection, and that scan is done from the skull base to the vertex of the skull. And at the clinical site where this exam took place, there are no different multi-phase protocols for age.
Okay, some other exam considerations for this patient were that because he had previous CT and MR exams, they already knew that he had no allergies to IV contrast and therefore didn't need any pre-medication. And when I talked to the techs at my clinical site, they said usually for the CTA head and neck, they don't adjust parameters to decrease dose to the patient, and I forget if they said if it was because of like the whole timing thing, or if they just didn't have that as a priority. But regardless, it is that they don't adjust anything, and they didn't use a shield for this exam in particular. Alright, so for the exam, they started off with a pre-contrast head CT using thin axial slices. Afterwards, they administered the IV contrast and then took pictures of the arterial phase, of the circle of Willis, and the neck.
And iterative reconstruction was used to reduce patient dose, and I couldn't find the exact model or the exact software associated with this particular scanner, but it was a GE scanner, which normally uses the adaptive statistical iterative reconstruction.
And 3D and MIP reformatting were used as well, and in case you forgot, MIP stands for Maximum Intensity Projection, which is a volume rendering 3D technique where they take the voxels with the highest Hounsfield unit values to include in the image. And so this helps out with IV contrast for better visualization, and they use this for bone as well, but for this case, obviously we're looking at IV contrast. And then afterwards, they do a post-contrast head CT using the same thin axial slices as well. So after all that, this kind of looks like there's a lot going on, but because this patient had a history of stroke, this particular CT exam showed that things were actually normal for him. So just to go into detail, the first scan of the head without contrast showed no hemorrhage, no edema or mass effect. The CTA neck showed a stenosis that they already knew of in his prior CTs, and then 60% stenosis of the right carotid bulb. For the CT neck with contrast, the findings were normal as well with compared to the priors, but a probable right atrial polyp was found. For the CTA head, again, they saw stenosis of the left MCA, but it was they said it was stable, but they already knew of this. But no other significant stenoses were found, and there was no aneurysm. Lastly, for the CT head with contrast, they said the recent left MCA infarct was better seen on the MR that took place the day before. Otherwise, there's no hemorrhage and no unusual enhancement, just chronic findings.
Okay, so for additional follow-up evaluations, they'll normally do an MRI of the brain with or without contrast. I've seen without contrast and with, but the MR is used really to visualize the soft tissue of the brain and look for any ischemic tissue, and it's normally done shortly after 12 hours or so, I think, after the CTs are done. In this particular patient's case, the previous MRI may have already given them enough information that they didn't need to do another one. And then, like Kelly said before, the delay scans that were acquired were post-contrast head with thin axial slices. Alright, and in this case, the patient was admitted for a few different tests and just continual monitoring and assessment of his condition. Since he had been in for an MRI the day before and then had come back into the ED the very next day, it seems like it was a situation where they needed to keep the patient there to monitor them and make sure that they were stable enough to be going back home, and to work with neurology to get specific recommendations for long-term care for the patient, since they were living in somewhat of an assisted living situation, and then also with physical therapy, occupational therapy evaluation of the patient, what they're capable of, and what they will need to help them with coping with their condition for the long term. And then they also really wanted to come up with a safe discharge plan so that the patient doesn't end up back at the hospital soon. And like I said before, there were echo procedures and other procedures that were done just to get more of a holistic base of knowledge for the complete health of the patient. And since the patient had diabetes and has a history of stroke, there could have also been education for the patient to mitigate any subsequent stroke potential, if that was a possibility.
So in closing, we were just going to talk about what we learned from this whole experience. And what I observed and what I learned was that when it comes to patients with stroke symptoms, fast teamwork is definitely a priority, because, you know, the quicker you do things, the better outcome for the patient it will be. And having up-to-date protocols was something that I noticed more in CT compared to our X-ray department. And it just seemed like everybody was had a very clear understanding of what needed to be done when, and there was less of that gray area compared to X-ray techs, where they take, you know, more liberties and saying, oh, I'm just going to do this protocol instead of like the written one that we have, just because like at my specific site our protocols are very old. I don't know the last time when they updated them, but I did see the CT department like always updating their protocols, so that was nice. And detailed chart notes goes a long way for patient care, especially seeing this patient go through multiple departments, and reading through the chart notes really helped get kind of a clear idea of what was happening and what they were planning to do. And then also I realized that, being a CT tech, you have to know how to problem solve even post-scan for reprocessing and reconstructive purposes, just to kind of see what reconstruction method would be most helpful for visualizing what you want to see.
All right. And I guess kind of to piggyback off what Kelly was saying, I did learn a lot from going through the process of scanning a patient from when the patient presents until the end when they're discharged. And I think that both taking good notes and getting a good history for a patient to provide the patient's chart with a good history, and also asking the patient and the patient's family for good history during and before the exam is something that is important in X-ray, but could maybe be even more important, especially given this patient's complicated issues in CT. I also think that teamwork and knowing your particular job within a stroke code and something that is such an acute situation is super important, and also being able to communicate really effectively so that the whole team can work as kind of like one efficient, cohesive unit to get some imaging that can be very, very important to the outcome for the patient. It was also just really cool to see all the things that we've been talking about in class actually in action, like the scan parameters and pitch and all of that. And I think maybe another one of the big things that I got just for CT in general is that I think a CT technologist has to wear more hats during their day, researching patient history before the patient is scanned. And maybe it's unique to Harborview, where my clinical site is, because there are a lot of residents that are putting in orders for CT exams, and so I found that CT techs were constantly finding discrepancies within orders and having to modify orders or change the way that they scan something in order to visualize what the patient's symptoms were showing. But I think that's something that's really cool about CT, that it's it involves a lot more critical thinking and maybe is a lot more interactive of a discipline than what I'm used to with diagnostic. And that will do it for our presentation. Thanks so much for watching, guys.
Thank you. Have a nice day.